If there's a single discovery that's revolutionized the field of retina and ophthalmology, optical coherence tomography, or OCT, is certainly on that short list, if not at the top of that list. As retina specialists, most of us can't imagine practicing today without OCT imaging. And in fact, it's one of the first diagnostic tests we obtain for the vast majority of our patients, and it's essential to the diagnosis and management of our most common diseases as well as our most rare. I am truly delighted and honored today to welcome a panel of legends who played a pivotal role in the development of OCT. We are so fortunate to be joined today by two of the original founders of OCT, Dr. James Fujimoto, who is the Elihu Thompson Professor of Electrical Engineering at MIT, and Dr. David Huang, who is Professor of Ophthalmology and Biomedical Engineering at OHSU School of Medicine, Wold Family Chair in Ophthalmic Imaging, and Associate Director and Director of Research at Casey Eye Institute. Additionally, OCT would not be where it is today without the researchers and clinicians who have guided our community in taking OCT from bench to bedside. And I'm thrilled to have with us today two retina specialists who had critical roles in doing just that. Dr. Jay Duker, Professor of Ophthalmology at Tufts and President and CEO of EyePoint, as well as Dr. David Sarraf, Clinical Professor of Ophthalmology and part of the Retinal Disorders and Ophthalmic Genetics Division at the Jules Stein Eye Institute, UCLA. Welcome to you four. Thank you so much for being part of ASRS History of Retina panel on OCT. Now, it's interesting. The four of you span sort of different parts of OCT's evolution. So we'll probably hear a little more from some of you initially, and then from others of you as we move further along the timeline. So Jim, I'll start with you. Tell us about how the concept of OCT was born. And this was a fascinating tidbit I learned from my research. Is it true that it was actually intended to be used in cornea as a light biopsy to measure corneal thickness?
Yeah, that's an interesting point. So we started working on ophthalmology in general because we were looking at short pulse laser technologies. Carmen Puliafito approached us to use high intensity short pulses for posterior capsulotomy, which was a popular topic at that time. And in addition, of course, that brings up the concept of keratorefractive surgery. One of the major applications of femtosecond laser technology is precision measurement. So we were interested in trying to measure corneal thickness, corneal incision depth using short pulses. And that was actually the initial concept for trying to use light to do measurements in the eye.
And David, fate, it's always interesting how it plays such a key role in our lives. And you were an MD, PhD student at this time, and Professor Fujimoto's lab happened to be next door to the lab that you were working in. Take us back to how you went from work neighbors to collaborators.
In 1989, I was finishing my master's degree, working actually in ligament biomechanics and building a tissue equivalent. But I was looking to change my research topic for PhD, and I looked at the next building on the same floor, third floor, building 36, and found Professor Fujimoto's lab working on laser stuff, which sound a lot sexier, more glamorous, and more interesting physics. So I joined Professor Fujimoto's lab for my PhD project. And one of the topics that he set me on was femtosecond laser surgery. And the other was using the interferometer to measure depth in tissue. And it's the second project that was more successful and turned into OCT. So we started by measuring cornea of all things. That led to the realization that we can measure really faint reflection from tissue down to 10 to the minus 10th or 1 in 10 billion photons coming back. And it's when we turned to measuring the retina that I realized that you can actually see reflection from internal structures, and that gave us the inspiration to make it into an imaging modality that's OCT today.
Jay and David, do you remember the first time you heard about OCT? And just kind of taking us back to this period of the late 1980s, was the community aware of the technology being developed, or was it still too early in its infancy? Maybe we'll start with Jay.
So at that time, I don't think the community was aware at all about the potential. Uh, the first clinical application to OCT was at the New England Eye Center at Tufts Medical Center. And Jim probably remembers the exact date, but sometime in 1993, 1994, Jim was able to place a working prototype at our clinic. My recollection is it took up half of a room. It required multiple PhD graduate students to keep it going. And Both Dr. Puliafito and Joel Schumann at the time were really, really interested in the clinical applications. And I was the head of retina at the eye center at the time, and they both were so excited, enthusiastic, and wanted me to image my patients. And at the time, I think I had the same attitude that many retina specialists had, which is we can put a Goldman lens on the eye and see everything we need to see. What do we need this for? And I still remember the patient that was the one that I suddenly realized how important and effective this was. It was a full thickness macular hole. And once I saw that cross-sectional image in such detail, I knew that this imaging modality was going to be really, really important to us.
I wanted to especially acknowledge Eric Swanson's involvement because I think he played a critical role. Eric was working at MIT Lincoln Laboratories, which is an Air Force research laboratory. We were fortunate to collaborate with him. And he was actually the person that took the initial OCT instrument from the laboratory to a prototype that could be used in the clinic. He designed the system that allowed much faster imaging, the patient interface. And then we also had group members, Joseph Izat, who was a postdoc at that time. He later became chair of biomedical engineering at Duke. He helped to manage many of the early clinical studies that were run by Carmen Puliafito and Joel Schumann. So I think this concept of going from a laboratory system to something that can be run in the clinic, that can be used on patients, was a critical step at the beginning.
Jim, in 1992, you and Eric Swanson and Carmen Puliafito founded an MIT startup company, which was called Advanced Ophthalmic Diagnostics, or AOD, to begin commercially developing the ophthalmic OCT. Tell us what that was like in terms of securing funding and putting yourselves out there on the map in the entrepreneurial world. That must have been a little bit of a shift from your typical day-to-day in the lab.
It was an interesting experience. We initially paid for it ourselves. And so, the lawyer's bill started going up and up, and we were very worried about it. We approached several companies. Actually, Carmen Puliafito managed a lot of the interactions. And then ultimately, the company that expressed interest was a division of Carl Zeiss that was managed by John Moore. And I think this is a very important point because John Moore, I think, really deserves a lot of credit. So he saw the potential of this technology, even though there was no precedent in retinal imaging at the time. And he decided to make the investment to develop this. And one point to note is that to commercialize something requires a multi-million-dollar investment, much more than the investment that you would incur in doing the fundamental research. So I think Mr. Moore was a visionary, and he really accelerated the commercialization, the availability of OCT.
Jay, you mentioned how it was very clunky and how it came with people from MIT to help run the machine. And it's just amazing now when you think ahead, how we've been able to get the OCT device into such compact sizes. I mean, the home OCT is 10 by 14 by 17 inches. I mean, what a way we've come. But I want to hear a little bit more about that critical period, and specifically, what were people's initial reactions to this technology as you began using it in patients?
So I would say at the beginning, there were really two barriers for acceptance. And the first is obvious. There weren't that many prototypes in the world. And so if only a few centers had one, it's very difficult for other clinicians to get excited about it or to really see the potential. So the ability for Zeiss to actually develop a commercial system that became widely available was critical. The second thing is right at the beginning, there was really no standards, so that the ground truth for a macular hole was what you or I said was a macular hole at the slit lamp with a 78 diopter lens. And while it seems inherently obvious when you get a high quality image of a macular hole with an OCT prototype that everybody agrees that that's a macular hole, but we had no real basis for ground truth. So a lot of the early studies that we needed to do would be imaging a lot of patients with a clinical diagnosis of, let's say, macular hole, and show, was it full thickness? Was it lamellar? Was it a pseudo hole? But until we established that OCT actually ground truth was better than what most of us could see at a slit lamp, that barrier really was in the way.
Well, in 1996, 2 years after Zeiss acquired AOD, OCT1 became the first commercially available machine. And this is, I think, the most fascinating part of the entire story because you would think it would be sort of a home run. But interestingly, it didn't do very well in sales. There were only about 180 units sold in a 3 year time span. And even its second generation iteration only sold about 400 units. But it seems like third time was a charm with the release of OCT3, which eventually became known as time domain Stratus OCT. And Jim, you earlier mentioned John Moore, who was president of Humphrey Instruments, which was a division of Zeiss at the time, who decided to commercialize the technology. And you give him a lot of credit because it was a financial risk, which obviously did eventually pay off, but it took some time for people to see its clinical value and figure out how to use it, to Jay's point earlier. Did that surprise you, Jim?
At the time, it did, but now, of course, there's tremendous barriers, as everybody knows, to developing something that's a new method that doesn't have a precedent. So I think this is a general theme that we're seeing in many areas. But from the viewpoint of Zeiss, this created a lot of stress. Because if you think they were very fast at introducing this to the market, but the sales were extremely low compared to any other product. This is terrible sales, right? Um, but at the same time, they made multiple iterations to the product. And I especially wanted to mention Jay Wei, who is the lead engineer at Zeiss at the time. He actually managed and designed the first three generations of OCT. He later went on to found OptiView, which introduced spectral domain OCT, the first FDA-approved spectral domain, and then also OCT angiography. So I think there's several people really that made critical contributions, and kind of by their faith and commitment, they helped to advance uh, both the technology as well as clinical medicine.
Absolutely. And it must have been incredibly rewarding to see all of that come to fruition, knowing that you'd played such a incredible role in that. Jay, I want to ask you, what do you think accounted for the difference in reception to the three release time points of OCT?
It's a great question, in that I have an opinion which may not have been totally the case, but the initial iterations were very bulky and very expensive and relatively slow. And the images that you got from OCT1 and OCT2 were not that good. People had seen publications from our eye center using the prototype, and the prototype that Jim built had better resolution than OCT1 or OCT2. And so I think some people just were disappointed that that imaging wow factor, let's call it, that we all saw with spectral domain wasn't there until the Stratus OCT3. The other thing that Zeiss did at that time, which I think really, really made a difference, was the normative database for nerve fiber layer. So, as retina specialists, a retina is thick, whether it's 500 microns thick or 457 microns thick. Thick is thick. We're going to treat it and make it normal again. Glaucoma specialists, of course, care about tiny little changes in the nerve fiber layer. And in order to really detect those tiny changes, you have to have a normative database to know what normal was. And I believe Zeiss did that early on with the Stratus. Then all of a sudden it shifted from this diagnostic machine for retina to a diagnostic machine for glaucoma. And I think that also was what really accelerated OCT3, or the Stratus, into what it's become. The software was much better, the speed was better, the imaging was better. And again, Jim, you lived through that era too. I don't know if you have another opinion on it, but I think the problem again is it took them three iterations to really build what I would call a clinically useful machine.
Jay, do you think the CPT code mattered, whether the clinical literature mattered, and whether anti-VEGF practice?
All of that mattered to a degree. But, with the publications, I think the beauty of OCT is interpretation of the images for most retinal diseases is simple. If you understand the retinal anatomy, you can tell what's normal is and what normal isn't. You don't really need a large publication to tell you that. On the other hand, the publications led to people thinking about other utilities. For example, we early on published a paper on telling peripheral retinal detachment from retinoschisis. That was always an issue, years ago in the clinic. You would call three clinicians in and they'd all say RD, schisis, et cetera. The OCT in seconds could tell you what you dealt with. But of course, David, what you really led into was, when did it go from being just a fascinating diagnostic equipment to a must-have therapeutic equipment. And it really started with the treatment of macular disease. Clearly, anti-VEGF is what we all think about, but it really predated that. I think I mentioned macular hole. Remember, we started doing macular hole surgery in the early 90s. And we'd go to a meeting and someone would stand up and say, oh, I get 70% of my holes closed. And another person would say, I get 85% closed. But their basis of closure was their post-op examination with a 70 diopter lens. Once we had OCT, it was leveled the playing field. It was quantifiable and repeatable. And then we really were able to assess what techniques really got us there.
Thanks for that input, Jay. I want to turn to David Sarraf about this because you were at an interesting junction in your career, David, when all of this was happening. And Jay mentioned this earlier, which I think is really interesting, that there was not really yet a ground truth set, right? We were all learning how to use the technology, what different findings would look like in various diseases. And you obviously have contributed greatly to that in identifying and teaching us about those novel findings on OCTs. But do you remember some of the first diseases that you imaged with OCT technology?
I think that Jay has really highlighted the importance of OCT for the diagnosis of macular hole and to validate closure after surgery. I think also CME was another very important pathoanatomical finding, even with a spectral domain OCT3, because again, you couldn't always be certain if you were seeing cysts there. There was always a certain skill set that you needed to use the 78 or the 90 diopter lens. To use transillumination. That's something that I would teach the residents and that Alan Bird taught me in order to see the cysts in the fovea. But that all became somewhat obsolete once we had, I think, even just the time domain OCT. And now we had a firm proof of CME, and then you could treat these patients. And again, you had a very reliable way to, track the response of your treatment. And so those were I think the important things. Epiretinal membranes as well. I mean, the whole evolution of our understanding of epiretinal membranes has changed, but that was another, I think, important way to sensitively detect that lesion that you wouldn't always appreciate just with biomicroscopic exam. But then when we got to spectral domain OCT, everything changed. The whole, I think, landscape changed, and it just kind of opened up a infinite opportunity to diagnose standard and new diseases.
And that I think really nicely feeds into this next question, which we've already touched on a little bit, but I'd love for all of you to comment a little bit more in depth on what that turning point for OCT to gain clinical acceptance and really become standard of care was. And David Huang, can you speak a little bit more on what you think was really the key driving force?
I think one thing that Jay mentioned before was the continuous improvement in image quality. The initial OCT systems had about 10 micron resolution in depth, and the initial speed was 100 XL scans per second. So that means after a few seconds, you get this low definition wavy image. And the speed of OCT has just continued to increase, following its own Moore's law, doubling every about 2.5 years. So just this continuous improvement in terms of resolution, definition, volumetric scanning, level of detail that you can see, and new contrast, field of view is improving steadily. So all these technology improvement is, I think, one major factor driving the increasing acceptance of this technology. The cost hasn't changed that much, so that couldn't be in it.
I want to go back to David Sarraf for just a second, because one thing that you shared with me about your initial impression of OCT that really stuck with me is that you found it interesting, you felt like it had potential, but didn't really fully realize its capacity until years later. And I think that's a common theme that you'll hear from many people who are involved in its early stages. And certainly you've really helped to drive that diagnostic capacity of this technology by identifying all of these novel features on OCTs that correspond to different disease states. Can you share maybe some of the publications or identifications that you're most proud of, either by yourself or maybe that you've co-authored with others or have been led by others?
Well, I think that there were a group of retinologists who were identifying novel findings. Jay was certainly one of those. Rick Spade, Bailey Freund, Voss Sada, Giuseppe Kerkis, I think over the years all Phil Rosenfeld, I think, also has had some very important applications of OCT. The one, of course, that what I remember was very impactful when I first saw it was the depth resolved capability of OCT for the first time allowed us to see ischemia at a deeper level. And I remember the moment my resident came to me with, it was a hard copy OCT B scan, and what I saw was a band of hyperreflectivity at the level of the inner nuclear layer, with the inner layer normal. And to me, that was a wow. Jay talks about a wow moment. That was a wow moment for me, because I was seeing almost like a histopathological level of disease that we could never ever appreciate. And of course, fluorescein angiography really just gives you predominantly imaging at the superficial level. No one had any visualization into the deep level, which was supply, the blood supply for the inner nuclear layer or the middle layer of the retina, and that was that scan that Rob Beersley was one of our Stein residents who showed that to me, was what led to our describing paracentral acute middle maculopathy, or PAM. And we subsequently understand that that's a middle level infarction that can occur in the milder stages of macular ischemia after arterial and vein occlusion because of the structure of the capillary network. So OCT was critical to allow us to make that observation and go back and look at the anatomy of the circulation, and then start to describe different diseases that had this association and better understand the structure of the capillary plexus. Of course, pachychoroid, I think, was also a massive observation by Bailey Freund, because that was now allowing us to see the choroid with enhanced depth imaging that was described initially by Rick Spade. By moving the Z point closer to the choroid, we were for the first time able to study the choroid. And then Bailey made the subsequent observation of a thickened choroid that may be a form frust or related to CSR even without fluid. And that just opened a whole universe of different disorders, related, unrelated disorders associated with a thickened choroid. And so those were, I think, two huge introductions to our understanding of macular disease as a result of OCT.
Jay, you spoke about your first aha moment when you were able to visualize the VMT attached to the edge of that full thickness macular hole, but that it also took demonstration of therapeutic purpose, right? Like you talked about your birdshot patient CME resolving after triamcinolone injection. It really took things like that for people to truly realize the technology's impact. Can you elaborate on that just a little bit more?
Sure, because that part is a fascinating story. We obviously had a prototype OCT, and we were in an era where wet macular degeneration was untreatable. There were a few clinicians out there who believed that one of the pathogenesis of wet AMD was inflammation and treated it with corticosteroids. So we had a resident, or fellow actually at the time, Adam Martinez, who had done his residency in Indiana, who had trained with a clinician who believed that corticosteroids worked in wet macular degeneration. So Dr. Puliafito had a patient with end-stage wet AMD and poor vision, and Adam convinced Carmen to try an intravitreal injection of triamcinolone, which they did. They saw the patient back in a month, and the visual acuity had not changed one bit. However, when they did a repeat OCT, all the macular edema was gone. So even though this was an end-stage patient who couldn't improve, it was clear that the intravitreal triamcinolone improved the macular edema, and it could be recorded quantitatively with the OCT. Coincidentally, sitting in the chair next door was a patient with birdshot chorioretinopathy and macular edema. And they did an intravitreal triamcinolone injection on that patient. And a month later, they came back, and not only was the fluid gone, but the vision was better. Now, that set off a whole idea of treating macular disease with medications. Adam came to me shortly thereafter and said, Jay, I think we should try this in diabetic macular edema. And I said, Adam, DME isn't an inflammatory disease. Why would it work? And Adam was 100% correct. We had the initial patient. I think I must have done 4 or 5 focal laser treatments on her, and she still had poor vision and retinal thickening. We did an intravitreal triamcinolone injection, and a month later, the fluid was gone and the vision was better. And Adam and I were the first to report that. Following it up, though, of course, Dr. Puliafito moved to Miami with Phil Rosenfeld there. And at the time, Phil was examining the use of anti-VEGFs first systemically and then eventually intravitreally for wet macular degeneration. And Phil's breakthrough, it's not that it wouldn't have been possible, but OCT sure made it much more acceptable. And because at that time, many of the clinicians around the world had access to OCT, I can recall after they published the first paper using Avastin for wet AMD, within 6 months, it was accepted really throughout the world as a therapy. And it couldn't have been accepted that fast without OCT. And again, Phil became the pioneer of using OCT as a biomarker for activity in wet AMD. And now I think most of us would agree you really just can't treat that disease without OCT to tell you the activity level of the disease.
Thank you. And I want to pick up a little bit on something that you all mentioned, which is that I think two of the things that were really important to highlight about the evolution of OCT are that resolution and speed have become better and better over time. And I think that's part of the reason why we love OCT so much. It's feasible, it's quick, it's non-invasive. Jim, I remember using the time domain OCT in residency, which is not that long ago. And wow, what a long way we've come in terms of resolution. And that's in part thanks to the introduction of spectrodomain OCT technology in 2006, which you mentioned earlier, which offered much faster scanning speeds. Can you tell us just a little bit more about that part of the evolution of OCT in terms of spectrodomain's emergence?
So I think that's an interesting story because spectral domain was developed simultaneously by three research groups independently. There was a group at Copernicus University in Poland who was working with the Medical University of Vienna. There was Duke University Joe Isot's group, and then a group at Massachusetts General Hospital, Johannes de Boer. And simultaneously, they all were working on the spectral domain concept, and they demonstrated that it would be possible to do very high-speed imaging because the signal to noise or sensitivity could be improved.
David Sarraf, I want to turn to you. Do you remember that transition from time domain to spectral domain, and how did that sort of play out in the real world clinical setting?
For me, the arrival of spectral domain OCT was really a huge breakthrough. At this point now, we're seeing all the 9 cardinal layers of the retina with great clarity. It spectacularly facilitated interpretations of the OCT. We actually wrote a paper, a series of cases where you could clearly see that the RAP lesion was descending from the deep plexus. And I think that really started an acceptance that RAP lesions or type 3 neovascularization were really not just located intraretinally, but originating intraretinally from the deep plexus. And then that was subsequently confirmed with OCTA. And to go from the time domain to the spectral domain, you could really validate that and confirm that with some degree of certainty.
Christina, there's another historical tidbit here to back up what David just said. Uh, some may recall when we started doing ICG angiography for wet AMD, we started to see in some cases what we called hotspots in pigment epithelial detachments. And at the time, we had a prototype OCT, but we didn't have the either sophistication or the ability to discern what David just talked about, that even with the prototype, we couldn't tell that those hotspots were actually CNV emanating from the retina. So they were identified via dye-based angiography, but we really couldn't tell until we had spectral domain OCT what their genesis was.
Love that. Thanks for adding that, Jay. David, did you have other thoughts? David Huang?
At the very beginning, actually 1991, we already, that's Eric, Jim, and me already thought that it was possibility to do Fourier domain detection for OCT. And I completely forgot about it after we discussed that. I remember writing a short memo about it, but then haven't thought about it for many years. I know Eric pursued swept source type of implementation, I think 97, but it didn't work that well. And then in 2002, I remember meeting Brett Buma and Johannes de Boer at a conference, and they told me like secret, something big is coming down. You wouldn't believe how well this is going to work. And then I wasn't sure what it was. I thought maybe it is something like Fourier domain. And then indeed it was, the spectral domain, the images, I just thought it was incredible that they could achieve such signal to noise level and speed. And I knew everybody was going to do retina with it.
What are your predictions and your hopes for future directions or applications for OCT technology? And maybe I'll turn the question over to Jim first. I mean, what do you want to see as sort of the next generation?
I think that the public health aspects are very important. So this comes back to the issue of, is it possible to do widespread screening to detect occult disease? But I think the problem there is the business model, the reimbursement, or who really is the payer for this. We know that this could be very effective. It would be good for patients. You would get high quality referrals in retina, but there's essentially business limitations to this.
And what do you think about using OCT to assess biomarkers outside of ophthalmology? Like, it's already starting to be done looking at things like heart disease or Alzheimer's. Do you think that's a real possibility?
I think that there's certainly a lot of evidence for this, and these are ongoing studies. I think with the advances in AI, it's possible to look at subtle changes, even in fundus images, but also with OCT angiography, that would, for example, classify heart attack, cardiovascular risk, Alzheimer's, neurological disease as well, kidney disease. I think these are all potentially quite possible.
We're already seeing with, we talked about PAM. PAM can leave a legacy of thinning in the INL that Matthew Bakum has actually referred to or coined the term ripple, which are retinal ischemic perivascular lesions. And these actually are systemic biomarkers for various systemic diseases, including hypertension, diabetes. And in the absence of those, it can also be a biomarker of cardiovascular disease, including prior MI and atrial fibrillation. And if I see these changes, these focal areas of thinning in the internuclear layer, I'm inclined to send the patient to a cardiologist, assuming there are no other risk factors, as I mentioned. So I think that there's a great opportunity to use OCT as a window or biomarker of systemic disease. And perhaps as we get greater acquisition speeds, we may be able to apply the OCT for these potential benefits.
David Huang, love your thoughts on this question.
Well, I think that the future of OCT in terms of growth will be in extending its use to primary care. And I think with artificial intelligence, we would be able to automate the operation and interpretation of the images. With integrated photonics, putting OCT on a chip, we can continue to improve the performance and lower the price at the same time. And then with oculomics, developing new ways to use OCT to detect cardiovascular and neurological diseases, again, also with the aid of artificial intelligence, would broaden the applications to make it worthwhile.
And Jay, to turn back to you, I share your interest in extending imaging technologies' powers as widely as possible. What are some of your other pie in the sky hopes that you have for the OCT of tomorrow?
So I don't think what I'm going to answer has not been covered already, but I may say it in a little different way. I see OCT going into three different directions. The first is a basic research direction, like it's been ever since Jim and David started over 30 years ago. How can we push the technology to teach us more about the anatomy of the eye and perhaps other organs? But ultimately, to go from a research tool to a useful clinical tool, we have to be able to treat disease. So even if we were able to, let's say, measure photoreceptor layer, if we don't have a way to preserve the photoreceptors, it will never be something that's clinically acceptable. The second way was also discussed. OCT used as a biomarker for non-ocular disease, and that is here now. Neurologically, certainly people are looking at Alzheimer's and other neurologic diseases. David Sarraf mentioned coronary disease, cardiac disease. up to 20% of MIs do not have atherosclerotic cardiovascular disease. There are other factors, and there is a possibility that we may be able to show with OCT to predict who's going to get those non-atherosclerotic MIs. And finally, I call it the dumbing down of OCT, which is getting it out into the community as a screening tool. And I'm not sure even putting it into clinicians' office like a primary care clinician is the way to go. We need to get it out into the community even more. And I think the hope there would be a healthcare system, for example, maybe a Kaiser, that we could convince in a closed system that if we could easily image all of their patients to get diabetic retinopathy and glaucoma diagnosed earlier, that it would be cost effective. Because ultimately, it really is true that we have limited resources. We need to use our money effectively, but we all agree making diagnosis earlier is better. So that, to summarize, I think those are the three prongs that advance OCT in the next decade, but each are dependent on a different type of funding.
Very well said. And as we wrap up here, Jim and David Huang, I wanted to take a moment to also congratulate you, along with Eric Swanson, on receiving the 2023 Lasker DeBakey Clinical Medical Research Award for the invention and development of OCT. Extremely well-deserved, as are your many other accolades. Well, as this entire panel has stated, nothing comes to fruition, especially at this scale, without a collaborative army of experts that involves engineers, researchers, clinician scientists, and business leaders. I'm glad that in our discussion today, we've had the chance to also recognize others who were pivotal in bringing OCT to where it is today. Carmen Puliafito, Joel Schumann, Jay Wei, Phil Rosenfeld, Cindy Toth, Eric Ippen, Michael He, Joseph Izat, John Moore, Eric Swanson, Rick Spade, Bailey Freund, to name just a few of them. And it's been so interesting and inspiring to hear about the journey of how OCT came to be, straight from the voices of four people who have been so vital in its development. Jim, David, Jay, and David, thank you so much for sharing your time and stories with us today.